Okay, you're here to get smart fast. Let's plunge straight into that sudden nasty pain in your side appendicitis.
The classic one everyone dreads.
Exactly. It's a key medical emergency, really. We all need to understand it well.
Mhm.
And we've, sifted through the notes to bring you the really core knowledge.
Yeah, cut through the noise.
Think of this as your sort of rapid fire guide.
Mhm.
Everything you need, no fluff. We're tackling it all, definition, causes, symptoms, right through to complications.
The whole journey.
So no time to waste. First off, what exactly is appendicitis?
Well, in simple terms, appendicitis is just when your appendix gets inflamed.
Okay.
You know, that small pouch-like organ attached to the large intestine. It can become, well, surprisingly problematic.
Right.
Usually it kicks off with a blockage. Something obstructs the inside, the lumen of the appendix.
And that sets things off.
Precisely. It causes a kind of cascade. Bacteria that normally live there quite happily suddenly multiply like mad. And that leads to infection. And then the inflammation follows. What's really striking is how quickly this can all happen.
Right.
An appendix that's blocked and inflamed can actually rupture if it's not treated. And that's serious, potentially life-threatening.
Okay, life-threatening. So a blockage is the initial trigger. What are the common causes of this obstruction?
Yeah, the obstruction. Well, the most frequent culprit is actually fecal material.
Mm-hmm.
Often it's hardened stool, what we call a fecalith.
Fecalith, right.
But it could also be, say, a foreign body someone's swallowed that finds its way there, or even enlarged lymphoid tissue.
Lymphoid tissue, like from the immune system.
Exactly. Part of your immune system reacting to something in the gut, perhaps.
Mm-hmm.
When any of these block the opening, pressure starts building up inside the appendix.
Okay.
And this increased pressure then impairs the blood flow to the wall of the appendix.
I see.
And like we just said, this reduced blood flow, combined with all those trapped bacteria just multiplying,
Yeah.
well, it creates the perfect storm for rapid bacterial growth and that inflammation we talked about.
Makes sense. And is there anything linking, say, diet to this?
That's an interesting point. Some research does suggest a potential link between low-fiber diets and a higher risk of these fecaliths forming. So potentially a lifestyle factor in some cases.
Interesting. And who's most likely to get this? Are there clear risk factors?
Absolutely. We definitely see some trends. Age is a big one.
Oh, yeah.
Yeah, the highest incidence is in the second and third decades. So teens and 20s mostly.
Okay.
Appendicitis is also slightly more common in males compared to females.
Right.
And it's worth flagging up family history, too. If it runs in the family, your risk seems to be a bit higher. Maybe a genetic link there, we're not entirely sure. And finally, people with underlying inflammatory bowel conditions like Crohn's or ulcerative colitis, they also have a higher risk.
Why is that?
Well, thinking back to the causes, that inflammation in the GI tract could lead to that enlarged lymphoid tissue near the appendix we mentioned, making an obstruction more likely.
Got it. Let's dig a bit deeper then into what's actually happening inside the body, the pathophysiology. We know obstruction leads to inflammation, but can you walk us through that sequence again?
Sure. It's really a chain reaction. First, the blockage traps the normal gut bacteria inside the appendix. They can't get out, so they multiply like crazy. That's the bacterial overgrowth stage.
Right. Overgrowth.
Then this overgrowth tips over into an actual infection. And the body's response to that infection, that's the inflammation, that's appendicitis.
Okay.
But a really critical factor here is the pressure buildup from the blockage. It doesn't just cause pain. It physically squeezes the blood vessels in the appendix wall.
Restricting the blood flow.
Exactly. Impaired blood supply.
No.
This weakens the wall, makes it more vulnerable to those bacteria invading deeper, and eventually it can lead to rupture.
Which is the really dangerous part.
Absolutely.
Yeah.
As we've said, if it isn't treated and that appendix bursts, it spills all that infected material into the abdomen. That causes peritonitis, a widespread, serious infection, potentially fatal.
Right. Definitely not something to ignore. Now, that sharp right-sided pain, it isn't only appendicitis, is it? What else could cause similar symptoms?
No, absolutely not. And that's such a crucial point for diagnosis. Because the symptoms overlap so much, doctors have this big list of possibilities, the differential diagnosis.
Okay.
So just thinking about gastrointestinal stuff first, it could be something relatively simple like a bowel obstruction or even just severe constipation causing pain, or more serious things like intussusception, where the bowel telescopes into itself, or a strangulated hernia, acute cholecystitis, that's gallbladder inflammation, or even a perforated peptic ulcer. They can all mimic it.
Wow. Okay.
And the list goes on. Mesenteric adenitis, swollen lymph nodes in the abdomen, often after a virus. Fecalith diverticulitis, Crohn's disease itself, other types of diverticulitis, pancreatitis, even a rectus sheath hematoma, which is bleeding into the abdominal wall muscle.
Yeah.
And sometimes even just a really bad case of gastroenteritis can present quite similarly initially.
That's a huge list just for the gut.
Yeah.
What about other systems?
Yeah. Beyond the GI tract, you have to think urologically too. Testicular torsion in males, that can cause referred abdominal pain.
Right.
Renal calculate kidney stones,
Right.
definitely. And urinary tract infections.
Okay.
Then in females, you absolutely have to consider gynecological causes. Things like an ectopic pregnancy, which is a surgical emergency, or torsion, twisting, or rupture of an ovarian cyst. Pelvic inflammatory disease, PID, all can cause lower abdominal pain.
Makes sense.
And then there are even less common things. Diabetic ketoacidosis can cause abdominal pain. Pneumonia, believe it or not.
Pneumonia, how?
Yeah, sometimes the inflammation near the diaphragm can refer pain down to the abdomen. Porphyria, which is a rare metabolic disorder. And even some side effects from certain immune therapies. There's a specific type of paniculitis, fat inflammation seen in the abdomen with some ejections.
That's quite a range.
It is. And one last thing, if the doctor actually feels a mass in that right lower quadrant, the RIF, they'd also think about things like Crohn's again, maybe colon cancer, a gallbladder issue called a mucus cell, a psoas abscess, a pelvic kidney, which is rare, or an ovarian cyst causing a mass. It just highlights how important careful evaluation is.
Absolutely. So thinking of the general population, how common is appendicitis? Do we have like UK numbers?
We do. Looking at the epidemiology here in the UK, figures suggest it's around 80,000 cases each year.
Approximately.
80,000, that's quite a lot.
It is. And while it can technically happen at any age, we see it most often in adolescents and young adults, as we mentioned.
Teens and 20s.
Yeah. And again, slightly more common in men than women. These numbers really just show how frequently doctors encounter this and why it's so vital to know the signs.
Okay, let's get into those signs and symptoms then. What's this sort of textbook classic presentation?
Right. The classic progression usually starts with this kind of vague abdominal pain, often quite central, around the umbilicus, the belly button.
Okay, starts central. Then, over several hours, typically, it migrates. It moves down and across to the right lower quadrant, the RIF. That shifting pain is really characteristic.
The migration, yeah.
Along with that, people very often lose their appetite. Anorexia is common. They might feel nauseous, maybe vomit, and they might develop a low-grade fever. And, of course, tenderness when you press on that RIF area.
And does moving make it worse?
Yes, typically. Pain is often worse with movement, jarring, even coughing.
Okay.
On examination, doctors look for that localized tenderness, maybe some guarding where the patient tenses their abdominal muscles involuntarily. And rebound tenderness is a key sign.
That's when it hurts more when you let go.
Exactly. Pain is worse on the sudden release of pressure. There's also a Robsing sign. Pressing on the left lower quadrant causes pain over on the right.
Interesting.
And there are a couple of other specific tests, like the psoas sign pain when the hip is extended back, and the obturator sign pain on internally rotating the flexed hip. Sometimes a rectal exam might show tenderness too.
You mentioned something earlier, a stage of illusion.
Ah, yes. That's important but tricky. If the appendix actually perforates, bursts, there can be a brief period where the pain suddenly seems to get better.
Better. Why?
Because the pressure inside the appendix is released. But it's incredibly misleading because now you have widespread contamination starting. So temporary relief, then much worse pain usually follows.
Wow, that's dangerous. You mentioned a memory tip.
Right. To remember that classic pattern, think. A pain in right iliac starts as general abdominal pain, then localizes to the right iliac fossa.
A pain in right iliac. Got it. But you also said presentations aren't always classic.
Very true. Atypical presentations are actually quite common. That's why you really have to keep appendicitis in mind for almost any acute abdominal pain.
So the pain might not move or might be somewhere else.
Exactly. The location can vary a lot depending on exactly where the appendix is sitting anatomically. It can be behind the colon, down in the pelvis.
Right.
And in specific groups, it's often different. Pregnant women, for example, the appendix gets pushed upwards by the growing uterus, so the pain and tenderness might be much higher up.
Okay, makes sense.
Infants often have very non-specific signs, maybe just watery diarrhea and vomiting. Young children might just complain of vague tummy ache and not want to eat.
Harder to pin down.
Definitely. And in the elderly, the presentation can be really subtle. Sometimes confusion or even signs of shock might be the main thing you see, rather than clear abdominal pain.
So given all this variation, diagnosis must be tough sometimes. You mentioned scoring systems. They help sort of quantify the risk.
Exactly. They're basically checklists, yeah. Combining symptoms, signs, and basic test results to give a score suggesting how likely appendicitis is. Especially useful when things aren't clear-cut.
What's an example?
Well, there's the ARIR score. It's got pretty good sensitivity and specificity.
Mm-hmm.
It looks at things like vomiting, definite RIF pain, rebound tenderness, temperature, the white blood cell count, and CRP level.
So clinical signs plus basic labs.
Right, a mix. Other scores exist too, like the adult appendicitis score, the Alvarado score, which is quite sensitive but maybe less specific, RAPASA, and the pediatric appendicitis score for kids. They all use slightly different combinations of factors.
Good to know those tools are there. So, okay, appendicitis is suspected. What investigations are typically done?
Well, it usually starts with blood tests. A full blood count, looking at the white blood cell, WBC count, that might be elevated with infection.
Right.
And C-reactive protein, CRP, another marker of inflammation, might also be raised.
Okay.
A urinalysis is pretty standard, mainly to rule out a urinary tract infection, which can cause similar pain, especially lower down.
It makes sense.
And crucially, for any woman of childbearing age, a pregnancy test is essential. Need to rule out ectopic pregnancy.
Absolutely. What about imaging?
Imaging is key. Ultrasound is often used first, especially in children and pregnant women, because it avoids radiation.
But is it always definitive?
Not always. It depends on the operator and the patient. A CT scan is generally more sensitive, better at actually diagnosing appendicitis.
But radiation is a concern?
It is, yeah. So low-dose CT protocols are often used now, trying to balance accuracy with radiation exposure.
What do they look for on the CT?
Key things are an enlarged appendix, usually over 6 millimeter diameter, a thickened appendiceal wall, something called fat stranding, which is basically haziness in the fat around the appendix indicating inflammation, and maybe enhancement of the appendix wall after contrast dye, showing increased blood flow.
Okay. Any other imaging?
MRI can be used, particularly in pregnant women, if the ultrasound wasn't clear. It's good, but slower and less available than CT usually.
And sometimes surgery itself is diagnostic?
Yes, exactly. In some cases, if the diagnosis is still uncertain after tests, a diagnostic laparoscopy keyhole surgery with a camera might be done to look directly at the appendix and confirm things.
Right. So let's say we have a diagnosis. What's the usual management plan?
The standard primary treatment is surgery, an appendectomy removal of the appendix.
Right.
Often, patients get intravenous antibiotics before the surgery to reduce the risk of infection afterwards.
And the surgery itself? Open or keyhole?
Both are options. Open appendectomy involves a slightly larger cut in the RIF. Laparoscopic appendectomy uses small incisions and a camera keyhole surgery.
Which is preferred?
Laparoscopic is often preferred these days. Generally means a shorter hospital stay, quicker recovery, less scarring.
Okay. So suspected cases get admitted.
Yes, admission is necessary, and supportive care is important to intravenous fluids if they're dehydrated from vomiting or not eating, and good pain relief.
Now, I've heard more recently about just using antibiotics, skipping surgery sometimes. Is that a real option?
Ah, yes. That's a really interesting and still somewhat controversial area. There's definitely been growing research into using antibiotics alone as the primary treatment, but specifically for uncomplicated appendicitis.
Uncomplicated meaning?
Meaning no signs of rupture, abscess, or widespread peritonitis on imaging, just inflammation of the appendix itself.
Okay. So how does that compare to surgery?
Well, surgery is still considered the gold standard, the definitive treatment. The main issue with antibiotics alone is the risk of recurrence, the appendicitis coming back later.
Oh, right. How high is that risk?
Some studies suggest it could be as high as maybe 39% recurrence within 5 years. So a significant number might need surgery eventually anyway.
Did COVID affect this discussion?
It did, actually. During the pandemic, there was a definite push towards non-operative management where possible to conserve hospital resources and reduce exposure. So antibiotic-only treatment saw a bit of a surge in interest.
So where are we now with it?
Currently, it's usually a case-by-case decision. For select patients with proven uncomplicated appendicitis, antibiotics might be offered as an alternative after discussing the pros and cons, especially the recurrence risk. It's about shared decision-making.
But surgery is still generally favored.
Generally, yes, particularly laparoscopic appendectomy, as it offers a definitive cure with good outcomes for most people. But sometimes, if the diagnosis is really uncertain initially, a period of active observation with reassessment might be used before deciding on surgery or antibiotics.
Interesting. So the future might see more tailored approaches, perhaps.
Potentially, yes. Identifying who might do just as well with antibiotics long-term versus who definitely needs surgery up front. That's where research is heading.
Okay. So if things go well, diagnosed and treated quickly, what's the prognosis generally like?
Generally, it's excellent. If appendicitis is caught and treated before it perforates, the mortality rate is very low, something like 0.8 per 1,000 cases. Really good outcome.
That's reassuring, but what if it does perforate?
If it ruptures, the risk does go up significantly. The mortality rate for perforated cases is higher, maybe around 5 per 1,000, still relatively low overall, but a definite increase.
You mentioned earlier it's worse in older people.
Yes, that's a really important point. In older individuals, particularly those over 70, the mortality rate can be substantially higher, unfortunately, potentially exceeding 20% in some studies.
20%? Wow! Why such a big difference?
It seemed to be a combination of things. Often, diagnosis is delayed because the symptoms can be less clear, as we discussed.
Right, the atypical presentations.
Exactly. Plus, older patients are more likely to have other medical conditions, comorbidities, that make surgery riskier and recovery harder. And some evidence suggests the disease might progress more rapidly in older adults, too.
Ah, tough combination. Okay,
Yeah.
let's talk about complications then. What can go wrong if it's not straightforward or treatment is delayed?
Several things can happen. Locally, right around the appendix, you can get an appendiceal abscess, a collection of pus walled off by the body.
Okay.
Or, as we've stressed, perforations, the appendix bursting. That leads to peritonitis, the widespread infection inside the abdominal cavity lining.
Which can lead to sepsis.
Exactly. If that infection spreads into the bloodstream, you get sepsis, which is a systemic, life-threatening emergency.
All right. Other issues?
You can get mechanical problems like a bowel obstruction, sometimes due to the inflammation or later from adhesions after surgery. Surgical site infections are also a risk, especially if the appendix was already perforated or gangrenous at the time of surgery.
What about an appendix mass? You mentioned that earlier.
Yes, an appendix mass, or phlegmon, that's where the body tries to contain the inflammation, the omentum, which is fatty tissue in the abdomen, and loops of bowel stick to the inflamed appendix, forming a sort of inflammatory lump.
How is that managed?
That's another area where there's some debate. Often, the initial approach is conservative, with antibiotics letting the inflammation settle. Then the question is whether to do surgery later and interval appendectomy to prevent recurrence. Practice varies quite a bit on that.
Okay. Any other potential complications?
You can get abscesses elsewhere, like a pelvic abscess or subphrenic abscess under the diaphragm. Paralytic ileus can happen where the bowel temporarily stops working due to the inflammation. And septicemia, blood poisoning, is another term for sepsis, really.
Long-term problems.
Long-term complications are thankfully rare after successful treatment, but the main one would be intestinal obstruction caused by adhesions, scar tissue, forming after the surgery or the initial inflammation.
Okay, lots to remember there. Any memory tips for complications?
Yes. Think of the P's of complications. You've got perforation, peritonitis, pus meaning an abscess. These can potentially lead to sepsis and problems with the passage, like bowel obstruction.
The P's. Perforation, peritonitis, plus sepsis, problems with passage. Helpful. Okay, let's try and consolidate all that.
Good idea.
So, appendicitis, inflammation of the appendix, usually kicked off by a blockage. Classic sign is pain moving to the right lower quadrant, but crucially, atypical presentations are common.
Very common.
Diagnosis relies on clinical suspicion, blood tests like WBC and CRP, and usually imaging ultrasound or CT.
Right. Main treatment is surgery, appendectomy, often laparoscopic. Antibiotics alone are an option being explored for select uncomplicated cases, but recurrence is a concern.
Exactly. Surgery is still the standard.
Prognosis is generally very good if treated promptly, but gets riskier with perforation, and especially in older adults. Complications include perforation, abscess, peritonitis, sepsis, and obstruction.
You've got it. Timely diagnosis and management are absolutely key for that good outcome.
Really insightful, thank you. It is fascinating, isn't it, thinking about how treatment is evolving, especially with the antibiotic question. Definitely something to watch.
Absolutely.
And for everyone listening, if you want to really nail down your knowledge on appendicitis and other essential topics for revision, do check out pastthem.MSRA.com and freemsra.com. Great resources there.
Definitely worth a look.